Okay, class. Last week we looked at normal gait patterns. We talked about cadence, stride length, step length, and now we're going to look at abnormal mobility. So looking at those gait patterns that are just not quite there, right? And you're thinking, okay, well, what is the problem? What do we tackle? Okay, so looking at gait from an abnormal standpoint is really enlightening because we can say, okay, what do we need to work on? So, and we'll not only look at gait, but we'll look at transfers, we'll look at stairs, we'll look at several things, but gait's the easiest thing to see because the minute a patient walks in the door or does not walk in the door, it tells us a lot about the patient. So we have impaired mobility function as one of the earliest and most characteristic symptoms of a wide variety of neurological disorders. So mobility is the critical part of maintaining independence and also important to quality of life. So if a patient isn't mobile, then they're just going to sit at home and not do much. So then there's a whole cascade of effects that can happen with that. So our job as rehab specialists is to keep our patients mobile or at least return most of their mobility. Type of gait abnormality dependent on type and extent of CNS pathology and the nature of resulting impairments and degree of compensation achieved by the individual is what we'll look at, right? So there's a plethora of different gait abnormalities, but we got to say, well, why is that patient A walking this way? Why is patient B walking this way? Because then our treatment is going to be totally different. So the ICF classification of mobility and disability, how does pathology affect motor, sensory, and cognitive systems on strategies used to accomplish progression and postural stability in steady state and ability to adapt gait and changing task and environmental demands. So we have to look at this whole model and we say, okay, we have a normal body structure, we have activities and participation. Well, if we have impairments, then those impairments will lead to abnormal gait patterns. And then abnormal gait patterns could lead to a plethora of things, such as activity limitations, participation restriction. So again, it all ties under the umbrella of the health condition or disorder. Now, what causes abnormal gait? Well, let's look at the classification of gait systems and also have links to other YouTube videos that will show what these patterns look like. Unfortunately, I wasn't able to put that in this YouTube because then there's like copyright issues. But you can, let's say we're talking about a gait pattern, gluteus medius weakness. You can just type in gluteus medius weakness on YouTube and you'll be able to see a whole bunch of examples based on that. So the gait classification, primary pathophysiological mechanism producing disordered gait, paresis, spasticity, loss of selectivity in motor output, and non-neural components. So there's a lot of things that can cause an abnormal gait pattern. Paresis, weakness, spasticity, loss of selectivity in motor output, and then there's sometimes just non-neural. It could be cognitive. Some of the neurological diagnoses that can come with abnormal gait patterns are Parkinson's disease, cerebellar ataxic gait patterns. So I'll show you what those look like. Suspected level of CNS involvement, the lowest spinal cord, middle, highest level is the cerebral cortex. So someone that has an injury to the spinal cord, their gait pattern may not be as affected as much as somebody that has the cerebral cortex involved. Okay, primary pathophysiology mechanism producing disordered gait. We have to figure out what is it that's causing that. Now, what if they have spasticity? Well, effects on certain key muscles during gait. Well, if they have plantar flexa, which is your gastroc and your soleus, they're spastic, so they're always in a plantar flex state. Well, that could affect the swing and stance phase because their toes might get caught on the carpet and they'll trip over. What if their quads are spastic? Well, you're going to get results in excessive knee extension during the stance phase, and their knee will kind of kick back. Okay. What about hamstrings? What if they're spastic? Well, they'll be more of a crouched pattern because their hamstrings are really tight. And then what if their hip adductors, the muscles on the inside, they'll have a scissoring gait where their legs cross over each other and they can trip easily on that. So spasticity is just as hard to treat as weakness. Now, spasticity contributes to disordered gait through inappropriate activation of muscle during the gait cycle. Most pronounced effects when muscle is lengthening. Also contributes to changes in mechanical properties of muscle, causing increased stiffness. What about, okay, you talk about spasticity, but what about if they're just weak? They have weakness and paresis. Paresis can affect the number, the type, and discharge frequency of the motor neurons essential for force production. So they can be tonic and phasic. Affects both the neural and non-neural components of force production. And weakness can adversely affect ability to generate forces to move body forward during concentric contractions. Restrain forward motion due to lack of eccentric control. And lack of eccentric control in quads or glutes can make forward progression or stair climbing very, very difficult, even descending. So if you look at paresis on gait, the compensatory strategies used to advance the swing leg despite inadequate hip flexion. So what they'll do is they'll either hike their hip, or they'll flex their hip or knee too much, or they'll have like a lurching gait and trying to get that clearance. Okay, so there's lots of compensations that patients can do. Describe the compensatory strategies being used to advance the swing here. So that can be a hip hike, okay, or a circumduction, or a, look at this, a toe off or a heel off, trying to clear that toe. The extent to which the weakness influences gait depends on a lot of factors, meaning what muscles are weak. What's the extent of their weakness? Do they have a little bit of weakness? Do they have a lot of weakness? And what's the capacity of other muscles to substitute? Ankle plantar flexors are the only muscles that come close to full capacity during gait. So if they have a lot of weakness in their ankle plantar flexors, then they're going to have a lot of issues. Okay, so those are one group that we really want to work on. What's the effect of lower extremity weakness on gait speed? Well, a person needs minimal level of strength to walk at a given speed. Association between walking speed and strength below reserve capacity threshold. But there is a strong relationship between knee extension strength and severity of walking disability among older women. So again, person needs minimal level strength to walk at a given speed. So really it's not a strength issue when it comes to speed, but there is a strong relationship with knee extension strength and the severity of walking. All right, we'll continue with this. Now, what about muscle weakness in the plantar flexors? Cannot restrain forward motion of tibia through eccentric contraction, results in excessive dorsiflexion and knee flexion. Also results in loss of heel rise at terminal stance and loss of terminal stance extension. So you have an excessive backward rotation of the pelvis, also likely at the terminal stance. All right, so now let's say they have a quadriceps weakness. So we looked at plantar flexion weakness, right? We looked at, now what if they have a quad weakness? Well, they're going to have uncontrolled knee flexion during loading. So difficulty stabilizing the knee during mid-stance. So they'll hyperextend the knee to lock out that knee so that they don't fall. And that hyperextension continued through pre-swing prevents free moving knee during swing, toe drag. So compensation is achieved through forward trunk lean, not always with positive outcomes. So their center of mass may change. What if they have hip flexor weakness? That will obviously affect the swing phase because they won't be able to flex their hip or knee. Reduction in loss of toe clearance, so they'll trip, shortened step and altered foot position at heel strike. So how do they compensate? They'll do a posterior pelvic tilt to an activation of abdominal muscles. They'll circumduct, that means swing their leg. They might vault on the other side. They may lean the trunk towards the opposite limb. What if they have weakness in their hip extensors? They're going to obviously produce forward trunk lean, compensatory backward lean in stance, but tibialis anterior activity needed to prevent backward falls. So these are all muscle weakness. These are great quiz questions that you can see is like, okay, if I have a weakness in here, in the hip extensors, in the hip flexors, in the quads, in the plantar, how will the patient compensate? Okay, and then one of the most common ones are hip abductor weakness, which results in a Trendelenburg, and that's a common compensation lateral shift of the center of mass over stance leg and lateral lean of the trunk in the same direction. So that's the Trendelenburg. Okay. Unlike spasticity, though, paresis, which is weakness, affects control of movement through loss of eccentric contractions. So it's the slowing down gait, generation of movement through loss of concentric contractions. Abnormal synergy, inability to recruit muscles selectively, abnormal coupling of muscles, and stereotypical movement strategies. Okay. What are some things that you can see with the abnormal synergy? Well, you can see presence reflects loss of fractionation of movement, muscle recruitment, and is due to corticospinal lesions. They can manifest as either total extension or total flexion during gait. Flexion synergy characterized by persistent flexion of the knee during swing phase or total flexor pattern at all three joints. Results in inability to extend the knee while flexing the hip during terminal swing. What about if they have coordination problems? That's usually a hallmark of neurological pathology, not immediately observable by looking at single joints in motion. Abnormal synergies defined as simultaneous recruitment of muscles at multiple joints and body segments, resulting in stereotype and relatively fixed patterns of movement. So their entire knee will flex, and their hip, and their ankle, or their entire hip, knee, and ankle will extend. So those are synergies, and that's usually a good telltale sign that they have some kind of neurological issue. Disordered patterns of activation, control patterns, impaired central programming affects muscle activation, manifests as inability to recruit a muscle appropriately, increased activation of muscle unrelated to spasticity mediated stretch, inability to modulate muscles activity throughout the gait cycle. Okay. What about if you have co-activation of the agonist and antagonist muscles? Right, so if your quads and hamstrings activate at the same time, that's defined as the loss of selective recruitment of physiologically antagonist muscles. Reasons for co-activation include pathologically disorganized central programs, additional postural support activity, immature gait programs, compensatory programming to increase muscle stiffness. What if they have impaired adaptation of gait? The inability to adapt gait is a critical factor that significantly limits participation in mobility-based activities, limits recovery of mobility in home and community environments, and of course it limits recovery of stability following unexpected perturbation if they get bumped into. They're going to have reactive balance problems. They're going to have proactive or anticipatory balance problems, impaired obstacle avoidance, impaired turning, inability to adapt to terrain changes. So some of the musculoskeletal impairments problems include weakness, loss of range of motion. They can have contractures. They can have changes in alignment. Results in reduced joint motion and ability of muscles to generate power at various speeds. If they have sensory impairments, they can have adequate sensation is critical determinant for maintaining gait, meaning diabetics have this problem. What if they can't feel the bottom of their foot? They don't have that sensation. Well, how are they going to get that feedback? Okay, so sensory input serves as a trigger for initiation of swing. So if they can't feel that their heel is touching the ground, how will they know to go into the next phase? Also needed for adapting locomotor patterns to changes in environmental demands. What if they abnormalities result in gait ataxia? For somatosensory, sensory ataxia results in inability of leg or even body position in space. Ataxia worse when visual cues are reduced or inappropriate. And loss of proprioceptive inputs results in reduced modulation of stretch reflexes during the gait cycle. So somatosensory deficits play a huge role in gait deficits. So we want to make sure that we're addressing all sorts of issues, right? Vision, somatosensory, weakness. There's a lot of issues that we need to deal with, not just one system. Okay. Visual deficits is critical to feed forward control of equilibrium during gait. So we have to know where we're going. Where's that visual feedback? Loss affects stability and adaptation aspects of gait. Obviously critical for obstacle avoidance. If you don't see that rock in the road or the bump in the road or a dip, well, you're going to fall, right? So visual deficits play a huge role. Hemianopsia can affect ability to perceive threats to stability on affected side. Now we've talked about somatosensory deficits, visual deficits. What if they have balance issues, vestibular deficits? Well, that's functional consequence of loss appears to depend on the age of the individual at time of loss. Gait's obviously going to be slower. Double support phase increases, right? They like to be on both their feet longer, and cycle time increases, so they just move a lot slower. May also show impairments in head stabilization during gait, especially in the dark. Okay. Perceptual and cognitive impairments. What about body image and scheme disorders? Can lead to a number of gait deficits, including trunk lean towards the stance leg, inappropriate foot placement, difficulty controlling center of mass relative to changing base of support. Unilateral spatial neglect often results in veering to the unaffected side, bumping into objects on the affected side. So if they can't see on the left side, they'll bump into objects on the left side. Spatial relationship disorders affect ability to navigate safely through the environment, avoid collisions with obstacles that are not readily perceived. Route finding is significantly affected due to inability to remember relationship of one place to another. Topographical disorientation is very common. And then, of course, there's pain that will limit our gait cycle. So pain is an antalgic gait is defined as a gait pattern that results from pain. So the definition of an antalgic gait is due to pain. Compensatory strategies include movements that reduce weight-bearing time on painful limb. Like let's say that you hurt your ankle, you hurt your knee, you're not going to put that as much weight on there. Avoid impact loads. Reduce joint excursion by limiting knee flexion during stance. Decrease joint compressive forces by minimizing activity in muscles that cross the joint. Cognitive impairments impact ability to initiate gait, adapt gait patterns to changing environmental demands, navigate in familiar and unfamiliar surroundings. Include deficits affecting memory, attention, and executive functions, and dementia. Definitely, dementia, Alzheimer's is a major risk factor for falls. Cognitive systems, impaired dual task walking. The ability for posture, balance, and gait required a lot of attentional resources. So if they're not paying attention, it's kind of like, you see people walking and texting at the same time and they'll fall. Well, that's the same thing, right? Attentional demands with postural control and stance and gait greater in individuals with impaired balance. Important to evaluate walking function under more complex conditions in persons with neurological pathology. So what factors may limit participation? Limited participation in mobility domain, debilitating aspect of neurological pathology, mobility disability, limited ability to walk in a home and community environment, and then there's community ambulations where they have balance, usual gait velocity and velocity on complex walking tasks, and strength in hemiparetic limbs. Okay, so those are a lot of things that would limit participation. We want to address all these factors and get them as mobile and independent as possible. Disorders of mobility other than gait. So let's say, what about gait initiation? They can't even start. They need to maintain dynamic balance while body's center of mass moves posteriorly and laterally towards swing limb and shifts towards stance limb and forward outside base of support and step is taken. Anticipatory postural adjustments that control dynamic stability are critical. What about stairs? Let's say they can't go up and down stairs. Well, stair climbing is reciprocal movements of legs through alternating stance phase and swing phases. Climbing is concentric forces at knee and ankle for forward and vertical progression. But the descent is key. If they don't have eccentric contractions of the hip and knee, they're going to fall when they go down stairs. So descending stairs is actually they might be able to go up, but most falls occur when they try to come down the stairs. What about transfers? Can they transfer from sit to stand? Many persons with neurological pathology report difficulty rising from the chair. They can't even get up. They have reduced force production, major factor. What about rise to walk? Characterized by a non-fluid strategy. They may have glitches or a cogwheel effect. Right? What about bed mobility? Can they go from one to another, meaning changing position while in bed? Can they roll supine to side lying or supine to prone? Can they get out of bed? Can they chair or standing up? They have initiated by movement of head, trunk, upper trunk, and shoulders. Overall, here's the take-home message. There's a great deal of heterogeneity, meaning difference among patients even with the same diagnosis. The same 2 patients with Parkinson's, the same 2 patients with strokes. Not all patients who have had a stroke will have a gait disorder. So treat everyone as an individual and don't use a cookie cutter recipe.